Now we will go to the questions. We have first question to Dr. Raed. What is the difference between fingolimod and spinomod except selective on S1B1? So spinomod is approved for secondary progressive MS, while fingolimod not approved for SPMS.
Thank you, Dr. Samar. The difference in the mechanism of action, sure, it is selective, less cardiac side effects, shorter
I can't hear you, Dr. Raed.
Can you hear me now? Can you hear me?
Yes, yes. We can hear.
So less cardiac side effect is an important difference, along with shorter washout period. And this is very important because, as you know, when with Gilenya, with fingolimod, it may take months before we reverse the lymphopenia. With spinomod, it should be shorter than this. With respect to the approval, fingolimod was not tested in SPMS, so they cannot approve it. However, spinomod was tested, and in SPMS, and around 20 to 30% of the trial were relapsing, not truly SPMS. That's why it received the approval for both relapsing remitting and secondary progressive. There is a strong inflammatory mechanism of action with spinomod, with all S1P inhibitors anyway. So I think the approval comes from the trial where they saw a strong inflammatory response. That's why it got both approval, the relapsing and the progressive.
Thank you, Dr. Raed. We will move to Dr. Suhail. There's question. Patient presented with optic neuritis, MOG positive, and the MRI brain is normal. Do you recommend to give him DMT?
Well, the question of DMT is, long-term therapies in MOG positive patients who doesn't have actually a brain lesion or otherwise is still, you see, under investigation. What you see, I think it is worthwhile actually to treat him with IVIG. I think the evidence now is mounting for the benefit of IVIG in MOG positive NMOSD, whether the brain is affected or not.
Another question for Dr. Suhail also. What is the dose of tocilizumab for NMO spectrum disorder?
You see, I have really, this is which one, eculizumab?
Tocilizumab.
Tocilizumab. Okay. Actually, I think we have to check it. It is not in the top of my mind now.
Any biomarkers is important and help diagnosis in NMO spectrum disorder like GFAP that may be used in MS. Is it used or can give benefit for diagnosis in NMO spectrum disorder?
Yeah, it could. It is, of course, a biological biomarker, and it may influence, you see, the monitoring of activity, response to medication, but that's still under study.
Thank you, Dr. Suhail. Dr. Namarek, do you recommend exclusive breastfeeding during the first 2 months? So during this period, you prefer to give interferon to protect your patient from getting relapse?
Well, it depends. It depends on so many patterns. It depends on so many factors, the disease activity. If the patient is stable before the getting pregnant and during pregnancy, postpartum period, we might actually even repeat the MRI postpartum without contrast to see if there's any new lesion. There are many factors to determine if the disease is stable and there is no evidence of clinical nor radiological activity, then no need to bridge the patient with interferon till we resume the DMT. It's actually, we can tailor it based on each case. We might actually consider if she has high disease activity, we might consider interferon beta, especially with the recent data suggestive that it is safe even during lactation period.
Okay. If patient is stable?
No need to bridge. She is stable. She's protected by the lactation.
And the only... stable and only exclusive breastfeeding for 2 months. No need for
yes, there is evidence that it is protective.
Thank you.
Yeah.
Yes, Dr.
Just to
Sui.
go back to that question, actually, we just
dose.
checked it with, I think, the dose of tocilizumab, right?
Yeah.
Yeah. It is given as IV or subcutaneous. And the IV dose actually is made 8 milligrams per kg body weight every 4 weeks. That's the dose.
Thank you. Last question to Dr. Namara. Do you recommend to use rituximab or ocrelizumab during pregnancy?
Again, it depends on the case. Now, it is recommended to use rituximab before pregnancy, especially if there is a high disease activity, to achieve a better controlling of the disease activity, especially if she was also on natalizumab or fingolimod. And then during pregnancy, there is no need to use or to give the patient an infusion of rituximab unless there are certain indications. If we give her the infusion before pregnancy and she gets stable and she needs to conceive of a period is not less than 1 month before getting pregnant, if everything is stable, then no need to give her during pregnancy. But there are cases, for example, if she was on natalizumab and then she got pregnant and then after 30 weeks of gestation, then she had a relapse. You can start rituximab in pregnancy to protect the patient because some relapses might be actually fatal with severe brain lesions, so we cannot underestimate that. So you have to tailor it based on
if she is
scenario.
on natalizumab and they get relapse, you prefer rituximab or go
yes.
to natalizumab?
So natalizumab, we can give it up to 30 weeks of gestation, and then there's definite risk factor, risk to the patient, to the fetus, including pancytopenia and thrombocytopenia. We cannot neglect that. She can continue natalizumab up to 30 weeks of gestation, and then you have more 10 weeks to go. If she got relapse, you can start. Some authors may suggest that you can start rituximab in a pregnancy. Although it might carry a risk of beta cell depleting in the fetus, which makes the fetus more prone to infection and he might not benefit from the vaccine. But then you have to weigh the risk versus the benefit, whether to wait postpartum to start or start in a pregnancy.
Thank you, Dr. Namara.
Question actually on my side to Dr. Namara. You see, with regard, you see patients who are on natalizumab, and, you know, for any reason, and particularly in the reason you have mentioned, you want to switch to rituximab. You know, both the drugs, they have a high, rate of causing PML.
Yes.
So is that really a concern to you? See, PML is well-known complication for therapists.
Yes.
You know, by giving them in success and without even a washing period,
Yes.
is that a concern to you?
Yes, absolutely. Now, the risk of PML is there mainly with natalizumab. There are different scenarios to deal with the patients having disease activity in a pregnancy. That's why it's from the beginning important to control the disease preconception, whether she's on natalizumab, and then if she gets pregnant on natalizumab. I'm not saying that rituximab should be started. It depends. Yes, the risk of PML has to be considered with repeating the dose. Now, the washout period for natalizumab, what is it like? We're waiting. It can be given in a pregnancy every 6 or 8 weeks. It's reasonable or rational even to delay the rituximab infusion postpartum. I mean, postpartum, she can also go back to natalizumab, not necessarily rituximab. What's more important is basically what happens pre-conception to shift the patient from natalizumab to rituximab. Yes, I agree.
It is unusual actually to have active MS disease in the second half of pregnancy.
Yes.
So most of these patients, if you cover them for the first 4 months, perhaps,
be protected, yes.
then the pregnancy effects will take over.
Yes.
Yeah.
So I
Thank you.
think it's better to advise our patient to be in remission for at least 1 month, 1 year before pregnancy.
Yes.
There is one question for Dr. Tariq. Here I received. Dr. Tariq, what is for how long you treat patient with the transverse myelitis? for how long you treat patient with the transverse myelitis?
So
And do you need to go for rituximab? And do you need to go for rituximab in these patients?
so the answer is as simple as this. Transverse myelitis in by itself is not a diagnosis as much as a presentation under a bigger umbrella of a disease process. So if it's idiopathic transverse myelitis and it's occurring one time, there is no indication for prevention. And if it is part of MS, so we're treating it as MS. If it's part of NMO, we'll treat it as NMO, right? The other thing is if it's isolated transverse myelitis, but it's recurring often. Now, it's not under a specific disease category, but being recurrent, so now we have to treat it in general. So I would use something like rituximab, more general, more safe. It will get a better control on it. And repeat the workup for a specific cause for this recurrent event.
I think the question is like if a patient having severe transverse myelitis, not responding, you went for a year trying to treat the patients still not respond. For how long you need to treat such patient? And if you don't find any benefit, do you need to switch to another immunomodulatory therapy? Or when do you stop and you say, that's it, that's the disease, and we have reached to the plateau in this disease and things is over?
Yeah, in regard to acute therapy. So again, if it's mild to moderate, if it's short segment, our first go is IV methylprednisolone. Now, if it is severe, there's severe weakness, there is a long lesion maybe, I will combine it from the beginning with plasma exchange. Further investigate, try to pin it down to what exactly is the cause between IV methylprednisolone and the added plasma exchange. The third option would be to add IV cyclophosphamide. And if there is still no response, probably we have to go back and re-examine our diagnosis. And is there still enhancement going on? That will make us probably dealing with something different.
I think it's done. Thank you. Thank you for the speakers. Thank you for the attendee.